Hey everyone, this is Dr. Medicine Alex, and in today's video we'll be discussing about treatment of syphilis. In syphilis, the drug of choice is parenteral penicillin, and it is always given after a test dose because sometimes patients can have undiagnosed penicillin allergies, in which cases it can be life-threatening. Therefore, giving penicillin only after a test dose is really important. Coming to treatment in cases of early syphilis, which includes the primary, secondary and early latent syphilis. For adults, we give benzathine penicillin G 2.4 million units intramuscularly single dose, where we give 1.2 million units in each buttock. Or we can also give procaine benzyl penicillin G 1.2 million units intramuscularly for 10 days. If the patient is allergic to penicillin, we can go for other alternative drugs such as doxycycline at a dosage of 100 mg BD per oral for 2 weeks, or tetracycline 500 mg QID per oral for 2 weeks, or erythromycin 500 mg QID per oral for 2 weeks. Coming to the follow-up of such cases, we need to do clinical and serological examination monthly for the first 6 months and thereafter every 3 months for the next 18 months. If in the first 6 months there is 4-fold decrease in the VDRL titer, then it is successful treatment. However, if there is no 4-fold decrease in VDRL titer, then we need to look for reinfection or treatment failure or HIV co-infection or even neurosyphilis. So at the end of 2 years, if the patient is well and the serology is negative and the CSF shows no abnormalities, then it indicates a cure. Next, coming to the treatment of late syphilitic cases, which includes tertiary cardiovascular neurosyphilis. For tertiary and cardiovascular syphilis in adults, we give benzathine penicillin G 2.4 million units intramuscularly every week for 3 weeks. That is 1.2 million units in each buttock. In late syphilitic cases, the treponemes, they multiply slowly. Therefore, there is a requirement to give treatment for longer duration. We can also go for procaine benzyl penicillin G 1.2 million units intramuscularly for 10 days. For follow-up, in these cases, we need to do clinical examination and VDRL at 6, 12 and 24 months. Next, coming to treatment of neurosyphilis, aqueous crystalline penicillin is the drug of choice, which is given at a dosage of 18 to 24 million units intravenously. This can be given either as a continuous infusion or as 3 to 4 million units every 4th hour for 10 to 14 days. We can also give procaine benzyl penicillin G 2.4 million units intramuscularly for 10 to 14 days, but here we need to combine it with oral probenecid 500 mg QID for 10 to 14 days. Oral probenecid increases the concentration of procaine penicillin in the CSF. Benzathine penicillin has no role in case of neurosyphilis because it cannot cross the blood-brain barrier. For follow-up of neurosyphilitic cases, we need to do CSF examination every 6 months until we get a normal CSF report. And the CSF cell count should also decrease by 6 months, and the CSF VDRL and protein levels should also decrease by 2 years. Coming to treatment in children, for primary, secondary and early latent syphilis, we need to give benzathine penicillin G 50,000 units per kg intramuscularly. This dosage can be given up to the adult dose of 2.4 million units in a single dose. For tertiary and cardiovascular syphilis, benzathine penicillin G is given at a dosage of 50,000 units per kg intramuscularly up to the adult dose of 2.4 million units, but it is given every week for 3 weeks. For cases of neurosyphilis in children, we go for aqueous crystalline penicillin G 50,000 units per kg intravenously. It can be given as a continuous infusion or every 4 to 6 hours for 10 to 14 days. Next, coming to the treatment of congenital syphilis. Here, in case of early prenatal syphilis, that is the case where the mother was diagnosed within the first 20 weeks of gestation, there is an increased risk for CNS infection in the infant. Therefore, we go for aqueous crystalline penicillin G 50,000 units per kg, 8 to 12 hours intravenously for 10 days. Here the dosage, it is given every 12 hourly for the first 7 days, followed by every 8th hourly for the next 3 days. We can also go for procaine penicillin G 50,000 units per kg intramuscularly for the 10 days. For cases of late prenatal syphilis where the mother was diagnosed after 20 weeks of gestation, we also go for aqueous penicillin G. But if the mother was adequately treated and the risk of neurosyphilis is low, we can go for single dose of benzathine penicillin G. Therefore, the treatment is aqueous crystalline penicillin G 50,000 units per kg intravenously as a continuous infusion or every 4 to 6 hours for 10 to 14 days. or we can go for benzathine penicillin G 50,000 units per kg intramuscularly up to 2.4 million units in a single dose. Next, coming to the reactions that we can see in case of syphilis. First is the Jarisch-Herxheimer reaction, and the second is the Procaine reaction. Procaine reaction is not as much important, but in Jarisch-Herxheimer reaction, what we see is that following antibiotic therapy in patients with spirochetal infection, there is going to be an acute inflammatory reaction, and this reaction, it is going to be acute and self-limited, and it is a febrile reaction. The etiopathogenesis, it is not well known, but it may be multifactorial because following antibiotic therapy, there is breakdown of the spirochete causing release of toxins and cytokines, which further lead to release of various interleukins and tumor necrosis factor alpha into circulation, which further produce the prodrome. So it manifests within 2 to 12 hours after the antibiotic therapy, and it lasts for 24 hours. It is more common in case of early syphilis, especially secondary syphilis, and it occurs as an all or none phenomenon. That is, it occurs with full potential if it occurs at all. Hence, starting the treatment with low dose penicillin does not give any protection. It is characterized by a triad of transient events where we can see fluctuation of the body temperature, there is going to be symptom flare, and there are going to be certain physiological changes. So in fluctuation of body temperature, we see cycles of fever as well as flu-like symptoms such as headache, malaise, chills, flushing and pharyngitis, and they kind of resolve within about 24 hours. Then there is going to be symptom flare, that is, there is aggravation of symptoms, and these symptoms, they vary in different stages of syphilis. Like for example, in primary syphilis, we see that the chancre is more edematous and or it has ulcerated, whereas in secondary syphilis, we see that the rash, it is more prominent in appearance, or in late syphilis, we can see that there is exacerbation of features related to different organ systems, or in neurosyphilis, we can see that there is aggravation of the existing psychosis or convulsions, or intensification of the symptoms in Tabes dorsalis. That is what happens in symptom flare. Whereas in physiological changes, we can see that there is increase in blood pressure, there is hyperventilation, later there can be hypotension due to vasodilation and decreased peripheral resistance. It can also lead to certain complications such as in pregnant women with early syphilis, there can be precipitation of the labor leading to fetal distress or premature birth, or there can be further intensification of the focal neurological deficit in neurosyphilitic cases. Sometimes there can be coronary artery occlusion or thrombosis or even rupture of aneurysms. The treatment is that this reaction, it is self-limiting and it resolves spontaneously within 24 hours. We just need to provide symptomatic treatment. We can give prednisolone at a dosage of 30 to 40 mg 2 days prior to starting the treatment for syphilis, and it is continued 2 to 3 days after. And we can also give IV infusion of fluids, NSAIDs and vasopressors when the reaction occurs. And if there are any complications, then we can go for TNF alpha antagonists, and in pregnant women, fetal monitoring is necessary. Coming to another reaction that can be seen rarely is the Procaine reaction, also known as Hoyne syndrome, where the patients are allergic to the Procaine part of Procaine penicillin or not penicillin. In such cases, in severe cases, we can see that there is acute psychotic episode due to brain microembolism. And in patients with penicillin allergy, if we have given the drug without any test dosing, then we have to immediately treat them with injection adrenaline, 0.6 ml, 1:1000 dilution with injection aminophylline. And we also need to give injection hydrocortisone 1 gram over 24 hours, and we also have to give antihistaminics. Coming to treatment in pregnancy, the treatment regimens are same as to what we discussed above. Even in pregnancy, penicillin is the drug of choice. If the patient is allergic to penicillin, then desensitization is to be done and we have to give penicillin. If at all it does not work out, then erythromycin can be used as an alternative. Thank you. Subscribe for more.